Good morning and Assalamu alaikum, everyone. I warmly welcome you all to episode number 11 of the College Research Committee's series of webinars on fundamentals of research. The topic for today is clinical audit. My name is Mohammed Umar Afridi, and I am a second-year medical student and the Assistant Director of Team Coordination in Student Research Committee at KMC, and I will be today's moderator. We are thrilled to have you all here and are excited to dive into this crucial topic with our esteemed speaker, Dr. Aliena Badshah. This is the 11th webinar of our webinar series and pre-conference activities leading to the third International Research Conference by SRC KMC. This resulted from the collaborative effort between Postgraduate Medical Institute and College Research Committee. This event is made possible through the dedicated efforts of Dr. Rubina, Chairperson CRC, Dr. Iqbal Haider, Chairperson Research Committee, Dr. Jahan Hassan, Chairperson SRC, and Dr. Ziauddin, PGMI's focal person. Additionally, it aligns with the vision of Honorable Dean of KMC, Professor Dr. Mahmood Aurangzeb, who champions the advancement of medical education and research. Respected participants, before we begin, I would like to go over a few basic ground rules so that we may have smooth proceedings and you may have the best experience. To receive CME accreditation, please ensure that you attend the entire webinar. Our team will be monitoring attendance and we will be sharing a feedback form at the end in this regard. Make sure to fill that out. You are all instructed to join with your real names, your real official names, for the purpose of certificate awarding. We strive to maintain a respectful and polite environment. Please be courteous and professional in your interactions. Ensure that you have a stable and secure internet connections. It is preferable to use a laptop or desktop. Our team will keep your microphone muted when listening to the session to minimize background noise. There will be a question-answer sessions at the end, and you are requested to speak out your questions, but before which it is advised to use the raise hand option. Alternatively, you can simply type your question in the chat box as a direct message to the moderator, and we will address them one at a time. The webinar is being recorded for future reference. By attending, you consent to being recorded. Now, it is my great pleasure to introduce our conversant speaker, Dr. Aliena Badshah. Dr. Aliena is an accomplished medical professional and academic. She graduated with MBBS gold medalist from Khyber Medical College in 2010 and earned her MRCP from Royal College of Physicians in Edinburgh in 2017. She completed her FCPS in medicine in 2018 and was awarded a certificate in palliative care of medicine from KMU in 2021 and has now become an MHPE scholar from KMU. Additionally, she completed an online stroke fellowship with the Association of Pakistani Physicians of North America. Dr. Aliena currently serves as the assistant professor in the Department of Medicine at KTH. She has an immersive portfolio of 50 research publications in national and international journals and is a member of Clinical Audit Committee at KTH. With this vast experience in conducting clinical audits, Dr. Aliena is a distinguished figure in her field. Dr. Aliena, welcome. Thank you for joining us today. Without any further ado, I now hand over the session to the speaker, Dr. Aliena. The floor is yours.
Assalamu alaikum, everyone. Thank you very much, Umar, for this nice and generous introduction. So we'll now start the formal talk. I hope it's going to be conducive, both for myself as well as for the esteemed audience. Can you please share the screen from the start? So today we are going to discuss how to conduct a clinical audit. I'm sure you all must have come through clinical audits, either as observers or some of you might have participated in clinical audits. But today we are going to learn how to get the maximum out of a clinical audit. Next, please. Our learning objectives for today's talk are, we may be able to define a clinical audit and also differentiate it from research and from quality insurance, develop insight into the need of clinical audits, and how to conduct a clinical audit, and lastly, how to publish a clinical audit. So these are the 4 objectives which we will try to achieve by the end of this talk. Next, please. So what is a clinical audit? It is basically a way to find out if healthcare is being provided in line with standards. Every country, every institute, every trust has a certain set of standardized guidelines by which they function. But it's not necessary that the practices are always following the principles. So the audit is conducted to see how much the practices are deviating from the principles. So an audit lets the care providers and patients know whether the service that they are receiving is good enough and where are the chances for improvements. Audits are a quality improvement measure, and these are also one of the 7 pillars of clinical governance. Next, please. So when we conduct an audit, we basically see what are the different types of practices going on in an institute. We being healthcare professionals would mostly talk about clinical audits in a clinical perspective. So that is at the hospital setting, whether it's a tertiary care hospital, a teaching hospital, or any other clinical setting. Over there can be problems coming in documentation. So we audit the different documentation that is going on in the patient's charts, in the nursing records, in the other documentation processes of the hospital setting. We can also audit the practices that are going on in a certain clinical setting. For example, the way you pass an IV cannula, whether that is in lines with the standards of passing an IV cannula, the way you take blood for certain blood tests, whether that is in line with the set practices, the way you pass a Foley's catheter, whether that is in line with the clinical standards for passing a Foley's catheter. So there are so many procedures that are going on in different hospital settings. I have just given you a few examples of the medical wards. Then we have the gynae wards and the surgical departments and the pediatrics, and so many other departments like psychiatry. The way you counsel a psychiatric patient, whether that counseling procedure or method is in line with the counseling procedures that have been set globally. So there are so many different options where we can dive into and check whether the practices are in line with the set standards. The way you give prescriptions to your patients, the way you prescribe medications on a patient's casualty slip or a general OPD slip, the way you give them discharge medications at the end of their hospital stay. Prescription method is in line with the international and global set standards. The different hospital policies, whether those policies are in line, the ones that are being practiced, are in line with the international policies of running a hospital. So there are many different ways in which you can conduct a clinical audit. When you conduct a clinical audit, you should also look at your own designation. If you are a postgraduate medical student, you might not be able to bring a huge change in the policies of a hospital, but obviously you can bring a change in the way you document the patient charts, the way you practice certain procedures. If you are a hospital administrator, these that are being practiced inside the hospital, and then you can bring a bigger change by changing those policies and getting them in line with the internationally set policies. Next, please. So in order to understand how we conduct a clinical audit, it's very important that we know what the clinical audit cycle is. When you know how to conduct a clinical audit by using the clinical audit cycle, it will become very easy for you and you will be able to conduct a clinical audit without any hesitation and without any difficulty. Next, please. So you see, it starts with identification of the problem or the issue at hand. Suppose you are a busy doctor on a medical ward and you identify a certain problem. For example, you see that your hospital is receiving a huge flow of patients. I'll just explain it with an example. So you see that you have new patients, but also of patients that have been discharged recently from the very same hospital, suppose say in the last week or so. So you identify a problem that why are these patients who have been discharged from the hospital only a week or 10 days back again getting admitted into the same hospital for the same reason or for the same issue. So you identified this problem. Then you want to see whether there is any problem with your discharge policy, whether these patients were discharged earlier, whether these patients were discharged prematurely. Why have they represented to the hospital again with the same problem in 1 week or 10 days? Then what you do is that you go through the literature search and you set certain criteria and standards. You go through the international criteria for discharging inpatients from a ward. Once you have set those criteria and standards, you prospectively follow newly admitted patients on your ward and you see whether these patients are getting readmitted in the next week or 10 days. You get a certain set of data, you make your results, and then you compare your results with the international results, whether the readmission rate of your hospital is the same as that of a standard hospital or not. If the readmission rate is high, then you need to readdress the issue. You need to set in a more stringent discharge policy. And if your readmission rate is in line with the standard guidelines, then obviously you are working well and you are scoring high. If suppose your readmission rate is higher than the set standards, you give recommendations for improving your readmission rate or reducing the rate. Then you implement that change once you have given the recommendations. And obviously, then you wait whether that change is being implemented or not. You get a second set of data, and then you can see whether the second set of data has improved from the previous set of data after implementing your recommendations or not. So this, as an example, was just meant to highlight how you start and how you go about it. It will become more clear when I give you a few examples of my own done audits, and then you will understand how it works. Next, please. Now there's another term, quality improvement. Quality improvement aims to improve the patient's experiences. In quality improvement, it's almost the same as a clinical audit, but clinical audits are always compared with a standard, with certain criteria. And then you see, in comparison to that standard and certain criteria, how are you functioning? In quality improvement, you do not compare your standards with another standard. All you need to do is you focus on prayer areas for attendants waiting in the waiting areas for their patients, washrooms for patient attendants, and other things that can bring about improvement in the quality of services that you provide. So this is what quality improvement is, and it's different from clinical audit. Next, please. Now, quality improvement works on this format. You plan something, for example, as I told you, you plan on arranging snacks or a snack room for the patients or the attendants, the casualty department. Then you do it. You plan it, then you implement study. How is the snack room or the restaurant or the tuck shop working in the casualty department? And then you act accordingly. If it's working well, you work on its consistency. If there are other needs of improvement, you work on the improvement. And that's it. You don't compare it with something else. Suppose in the month of Ramadan, you arrange aftari for the patient's attendance on the admitted patients on the wards. And then you do it, implement it, and then you see how it's working. What is the feedback of the patient attendants? So these are small goals, small aims, and you don't compare them with any certain standards. But in the case of a clinical audit, you always have to have a set standard with which you have to compare your own practices. Next, please. So this is what I've already explained. Audits are more formal standards, and audits obviously tend to take a longer time period. You have to conduct an audit almost in 3 or 4 months. It cannot be less than 3 or 4 months, because you identify a problem, then you come up with you then gather data about it, then you come up with recommendations, then you implement those recommendations, and after that you see the change in the practices. So obviously it's not going to take, is a shorter duration activity. Next, please. So what are the benefits of conducting a clinical audit? Why should we be conducting a clinical audit? They help to improve patient care. Obviously, if you are practicing in a busy hospital and at the same time you want to see whether the services that you are providing are actually helpful and are whether they are improving the patient care, then you can conduct clinical audits. They also show your interest in a certain field. Obviously, if you are conducting clinical audits on, suppose, patient benefits, on documentation, on prescription, on different practices that are going on in a hospital, they also show your interest in that certain field. And they also, you are able to learn many transferable skills, because a clinical audit is not conducted alone. It will always be conducted in a team where you will have a lead, a supervisor, and then there will be team members. So it basically enables you to work in a team, at times as a leader, as a supervisor, and at other times as a learner. So in this way, you are enabled to work as a team. You have active time management skills, and you gear up to develop all these transferable skills. These audits can also be presented at conferences, and you can also demonstrate the practices that you have come across to other healthcare professionals, and you can also then further publish these skills. So these will help you to become better practitioners and better researchers. When you present your clinical audit in a conference, it strengthens up your work and it shows up your potential as a clinician. Obviously, if for the undergraduates and for the postgraduate trainees, these audits also earn you extra CV points. So that's an added benefit. And as a doctor, it can also become a part of the annual appraisals and assessments. In our setting, it can improve upon our PERs. Our faculty will be aware of the word. So obviously, it's not, I'd say these are very rewarding, keeping in view the fact that all you get from a clinical audit is benefit. You can benefit your patients, you can benefit the hospital administration, you can also benefit your team member, and you yourself get benefited, that it adds up to your CV and you can present and publish it. Next, please. So what are the criteria for the audit selection? The criteria for audit selection are not different from those for any research. The audit that you are selecting must be specific. You should choose an area that you are interested in, and it should not be too broad. Like if you have 3 or 4 problems to address, then it's better that you address those 3 or 4 problems in 3 and 4 different audits, rather than addressing all those problems in a single audit. So it should be specific and it should be measurable. Whenever we talk about research, whenever we talk about clinical audits, it's always the statistics that count. So you should have exact numbers, exact figures, exact digits, because by the end of it, you are going to present data, and data always is numerical. Obviously, you do have categorical data as well, but if you are going to show improvement, so then improvement is better addressed by numbers. And your audit topic should be such that it should be achievable. As I've already told you in the start, if you are a medical student, you should keep yourself limited to those audits which are under your domain. If you are a postgraduate trainee, you should keep yourself limited to those audits that are under your domain, and also audits that are achievable. Your audit should be realistic and it should be timely as well. If you have a topic in mind that might need almost a year or 2 years to give you the results, then I think it's better to leave that to a later stage and select other audits which can be done in a few months' time and give you ultimate results. Next, please. So this is now the main crux of the presentation, that steps of conducting a clinical audit. You have an audit team that comprises of 4 or 5 members, and you have a lead for that. The lead is the person who is going to lead you and assign you tasks, and all the audit team members comply with those tasks, and by the end of it, they meet and then they discuss their performance. Before you conduct an audit, it's always imperative to take approval from your own hospital audit committee. Every institute has an audit committee, and whosoever is conducting a clinical audit should take approval from the audit committee. See, whenever you conduct a clinical audit, you should have it on paper, it should be documented, and it should be formal. Then you should keep your audit committee informed and updated about your progress. It's not that you've just taken an approval and then you are doing the audit on your own. You should always keep them informed and updated about the progress of your work. Then ultimately you present the clinical audit and you come up with recommendations. And obviously there are ways and means that are designed by the hospital administration to implement those recommendations. As a clinician, all you can do is you can give recommendations. You might not be able to implement those recommendations because that might not be the domain of your responsibility. You give out certain recommendations, but how to address those recommendations and how to implement those recommendations is the responsibility of the hospital administration. Those recommendations will be communicated by the audit committee to the administration, and then they will implement those recommendations if they feel and deem appropriate. Now, this completes your clinical audit, and obviously you can then see what is the progress of your audit. Next, please. Now I will share a clinical audit proposal template with you all, so you know how it goes about. Next. Thank you. So this is the clinical audit template of our own hospital, of Khyber Teaching Hospital. So you see, it starts off with the title. You write a clear title. As I already told you that it should be smart, you have to be specific, and it should be measurable, and it should be achievable and realistic and timely. That title comes over here. Then you write the name of the audit lead, their name, their specialty, their job title, their telephone or contact number, their email address. Please make sure that you always use your official email ID whenever you are conducting a clinical audit. And obviously then the audit supervisor, if it's a junior doctor that is conducting an audit, they will be supervised by someone, either their supervisor or by a senior. So that should also be documented. Then you see there's a sentence, is this a re-audit? So at times what we do is that we conduct one audit, and then after some time, after a gap of a few months, we see whether the recommendations that we had suggested have been implemented, and what have the practices changed after implementing those recommendations. So we can conduct a second round of an audit as well. So if it's a re-audit, you tick it, mark it tick over here. If yes, have previous audits actions been implemented? So you write whether yes or no. Then the scope. How broad is the focus of this audit? Is it national? Is it local? Because if you are conducting a clinical audit, you should also see whether your audit is going to have any impact nationally, internationally, or only in your own hospital setting, or only in your own ward. So if it's going to have an impact in your own department, it definitely is a good audit, but it might not have much impact elsewhere. And if suppose it's an audit that is going to have an impact nationally, then it's obviously going to carry more weightage as well. So you have to document it, whether it's a national level audit or which level audit. Is it multi-professional? Is this audit going to have impact on other departments as well? Or it's only going to have impact in your own department? So then you can document the change over here. We had conducted a clinical audit on whether stroke patients that are admitted to our hospital are undergoing the swallow assessment within 48 hours of their admission, which is the set guideline. Now, when we conduct this audit, you can see that stroke is a condition that is not only limited to medicine, It is also limited to physiotherapy department, the speech therapists, because obviously if you are going to check their swallow and do their swallow assessment, so it is also going to involve the physiotherapy department, the speech therapists, the neurology department, and obviously the radiology department, because they are going to conduct a CT scan and then guide us whether the patient is having a bleed or an infarct or otherwise. So this is a multi-professional domain. You have other professions on board, other departments on board with you as well. So if it's a multi-professional domain, then you tick mark it as needed. Next, please. Rationale for the audit. Why are you conducting this audit? Is it going to bring a change in service? Or is it an area of high risk? Suppose you are talking about hepatitis B, C, or HIV contamination, or prick marks, or prick injuries, or something like that. So definitely that's an area of high risk. Or suppose if you are conducting an audit on surgical site infections or methicillin-resistant Staph aureus infections, then these are areas of high risk. Or whether the audit is on new and updated guidelines, whether certain guidelines have changed and your hospital is still following the older guidelines. So whether you want to conduct an audit on that, whether you want to conduct an audit on high cost. For example, as those who are working in the tertiary care hospitals would be aware that fever patients these days are treated empirically mostly with meropenem. And meropenem is a very good antibiotic, but at the same time, it's a very costly antibiotic. Mostly the patients that we receive with non-focal pyrexias, with non-focal fevers, they have already received so many antibiotics in the periphery that by the time they reach us, we are not left with many options. And we have to treat them with antibiotics that are going to have high potency and high efficacy. But at the same time, we might be causing extra costs. So any drug, any procedure, any intervention that is costly, we can conduct a clinical audit on that. Whether it has something to do with adverse events, or it is involving a high population of patients, or a certain complaint has risen about a certain practice, or a certain documentation procedure, or a certain practice that you are doing on your wards. The patients have risen those complaints, the attendants have risen those complaints, and then you can conduct a clinical audit on that and see what's the problem. So you tick mark accordingly, then you write a brief background of your clinical audit, the aims and objectives. And as I mentioned, aims and objectives should be 1 or 2, not more than that. If you have more aims and more objectives, try to conduct other audits on those aims and objectives. Next, please. So then the project team details, again, their name, the job title, the specialty and the role, whether they are leads, whether they are team members, and then you keep on adding other team members. Then if suppose you have team members from other departments, then you can add on their names to the second column and second row. Next, please. So then you talk about the audit standards, that if you are conducting a clinical audit, what are the standards that you are using? Are they local guidelines? Are they NICE guidelines or Royal College of Physicians guidelines or guidelines from an American or Canadian or some other standard? So you specify and then you give their reference. And as you all would be aware that the guidelines which you are setting as your standards should not be more than 5 years guidelines. Even if they are years old, but you should make sure that these guidelines are more than not being your methodology, the data collection. What type of data collection are you going to do? Are you going to check it in the patient's notes, or you are going to use your hospital database like we have the HMIS in the Heber Teaching Hospital, or whether you are going to have questionnaires for that. So whichever is your mode of data collection, you should document it over here. And then you should also document your selection criteria, exclusion criteria, and your sample size, which is important for publication of the clinical audit, and also the time scale. for how long are you going to run the audit, and for how long are you then going to analyze the data, and then when are you going to present it. So a rough time estimate of almost 3 to 4 months should be mentioned. Then whether patients will be involved, who will be involved, and whether you would have taken consent from them, that should also be documented. And once you have gotten the results of the clinical audit, how are you going to disseminate your results? How are people and the hospital personnel going to get aware that an audit has been conducted and it's the time to change certain practices? So either you present it, or you write a written report, or you publish it. And ultimately you sign in the declaration. So this is the template for the clinical audit pro forma. Once you have, only then you can start working on your clinical audit. Next, please. So now this is an audit that we conducted recently in April. Documentation of NIH stroke scale in initial assessment of ischemic stroke patients and its use in determining thrombolytic therapy eligibility and long-term prognosis. So a clinical audit and quality improvement cycle. Now, this was an audit that was conducted by myself and a few other TMOs, as you can see, and we wanted to see where the stroke patients that are getting admitted to a hospital or that are presenting to a tertiary care hospital, are they being assessed on the basis of the NIH stroke scale, whether that NIH stroke scale score is being documented in the patient's charts, because it's very important to know about the NIH stroke scale of a patient. You can check their eligibility for thrombolysis, and at the same time, you can also guide them and yourself and your practices about their long-term prognosis. So the audit team, the background, the guidelines, these have been mentioned. It was the NICE guidelines which we compared our practices against. Next, please. We mentioned the aims and objectives of the audit. Then we conducted the first round, and we went through records of patients over a month, the stroke patients that had presented to all 4 of our medical wards and casualty departments and OPDs, and we checked their records, and we analyzed that how many stroke patients had been checked on the basis of the NIH stroke scale. Next, please. So as you can see that 100% of the patients that had presented to our hospital were not assessed on the basis of the NIH stroke scale. So there was not a single chart or a single page that showed documentation of the NIH stroke scale on the stroke patients charts. So these were the results from the first round. Next, please. We took some steps to improve practices. We did in-ward presentations to our house offices and postgraduate residents and ward seniors and consultants to try to actually counsel their juniors and try to imply upon the juniors that they should document the NIH stroke scale in the charts of patients presenting with stroke. We try to encourage them and educate them, and we, on our daily morning rounds, we would try to guide them whenever we would be standing at the bed of a stroke patient, that the NIH stroke scale should be documented in their charts. So this was the first step. In all the medical wards of our hospital and in all their WhatsApp groups, it was circulated that they should be documenting the NIH stroke scale in the charts of the stroke patients. Next, please.
Ma'am, there's a question in the chat box from a name. He's asking, is assessing NIHSS as long-term prognosis, is it in the scope of audit?
Okay, thank you for the question. No, that's not the scope of an audit. My point of communicating this point over here was that when we are conducting a clinical audit, we should know why we are conducting it. So it's just to imply the importance of the NIH stroke scale, that documentation. See, if you are doing something, you should document it. If it's not being documented, it means you are not doing it. If you are not doing it, it means you do not know what is the importance of actually doing it. So when you check the NIH stroke scale of a stroke patient and then you document it, you know its importance. So that's just to highlight the importance of the NIH stroke scale, that it is important in assessing whether this patient is going to benefit from thrombolytic therapy or not. And also it helps you in the prognosis of your patients, and you can guide their family members accordingly. So it was just to highlight the importance of the NIH stroke scale. You are right, it's not the domain of a clinical audit, but it's for you, since it's a webinar and obviously people might develop certain confusions when it's not face to face. So that was just to highlight that thing कि हमने audit कराया इसलिए था क्योंकि NIH stroke scale के ये फवायद है, तो हमने इसलिए ये audit कराया कि NIH stroke scale जो है तो वो document हो रहा है कि नहीं हो रहा, ठीक है? So what happened was that we communicated it to everyone that they should bring in this change, and then we waited. After a wait of almost 1 month, we again collected data and then did our second round of audit to see whether the healthcare professionals are documenting the NIH stroke scale or not. So again, next please. Okay, so you इसे पीछे slide कर लें जरा please. Yes, so as you can see that in the results section, that we assessed a total of 21 patient charts, the patients who had presented with stroke to our inpatients over 1 month. And in 19 charts out of 21, the NIH stroke scale was still not documented. So initially the results were 100%, and now they reduced to 90.5%. So despite all this dissemination of information and dissemination of implementation of our practices, only 2 charts were showing out of 21 the change that we were expecting in almost all the charts. So the results again are not very good despite all this thorough workup that we did. Next, please. So it shows that this way of dissemination that we did might not have been very effective. You should at this point also understand that when you do a clinical audit and when you try to implement your recommendations, even if you do not get the results that you expect, even that's a very good result, because it actually guides you that your method of dissemination of the information or your method of implementing those recommendations was not right. So you might need to come up with certain other methods to actually implement those recommendations. So as you can see, we came up with these discussions that there might be problems in human factors of engineering, or the effectiveness of our strategies might not have been too good, or we might need to educate our junior doctors further, or we might need to bring about certain policies that might give us better implementation. And then we came up with a recommendation from the Clinical Audit Committee lead that it's better to actually design certain charts for our stroke patients that have already got the NIH stroke scale documented in it. And all that the junior doctors need to do would be to fill it in because it would already have been provided to them. So then they might be at a lesser risk of not documenting it. So obviously you do learn from all these different steps of clinical audit writing. Next, please.
Yes, ma'am. Another question from Ishtiaq is, do we mention audit and re-audit in the same report, or are they published separately?
When you are conducting a clinical audit at the hospital level, you mention your audit and re-audit to the Clinical Audit Committee separately. But when you are publishing them, it's always better to publish them together, because in this way, those who are reading your audit would know what were the results of your first round, what sorts of strategies you came across, how you implemented them, and what were the results of your second round. So the nutshell will be provided to the readers in a single published clinical audit. But when you are conducting a clinical audit, so it's always good to do it in 2 steps or 3 steps even. It depends on the domain of your audit. So these were the different suggestions that we came across from our audit, and we are still in the stage of implementing these. Next, please. Now we have got another step, that is publishing a clinical audit, because all the researchers are always interested in publishing clinical audits. All sorts of data, all sorts of information that you have got will be lost if you do not publish it, if you do not make it public. So it's always good to publish a clinical audit. Now, which type of audit will get itself to be published? So if it's a local audit that is not going to have a high impact, it might find its way to a local journal. If it's a national level audit, it will find itself in a national journal. If it's an audit that is going to have a huge impact, it might find its way even to an international journal. So it depends upon the impact that your audit is going to create. Now, the example that I've given in my audit, that was the NIH stroke scale, it might not have a global impact, because globally they might be having separate charts already. Globally, they might already be having the NIH stroke scale documentation going on. So it's not going to impact globally. But if we can even bring out a local change, keeping in view the fact that we have to always try to compare our practices with international guidelines, so it can find itself in a local journal or a national journal. Next, please. Now, when a journal is accepting or not accepting your clinical audit, what does a journal look at? You see, every journal has its own readership. A journal is not going to reduce its standards for your clinical audit. It is going to see certain points in your audit with which it is going to actually accept your clinical audit. So what are those points that your clinical audit should have for a good impact factor journal to accept it for publication? Whether your clinical audit is going to improve outcomes, whether it is going to improve patient outcomes. So that's very important. Is your clinical audit going to improve structures? For example, as I told you, that if you have conducted a clinical audit, you have disseminated all the different guidelines and the information, but people are still not complying with it. And then you have come against another idea of setting clinical coordinators or other coordinators who might be roaming about in the hospital and guiding people on bringing the change. Then that's a good clinical audit. If a clinical audit is being conducted that is going to improve certain processes, for example, there was a clinical audit that was done on the irrational use of antibiotics in the hospital. So what they came across was they devised a clinical scoring system. A clinical scoring system was devised that patients who present to the hospital will all go through the clinical scoring system. And if by that clinical scoring system they are found eligible for antibiotic use, only then they will receive antibiotics. If not, they will not receive antibiotics. So with the help of that clinical scoring system, the irrational and the erratic use of antibiotics reduced tremendously. Now, this was a good audit, because with the help of that audit, with the help of that clinical scoring system that the audit team devised, the irrational use of antibiotics was reduced. So obviously, outcomes improve, there is cost effectiveness, and patient benefit is there, antibiotic resistance is reduced. So this type of an audit is going to find itself into publication. Generating benchmarks. If with the help of your audit, you create a certain pro forma, a certain guideline that can be implemented, with the help of which you can get better results, be that in the case of patient care or in the overall impression of your hospital, that is going to find its way into publication. And showing clinically important correlations. Another audit was done, which basically found out that there is unnecessary blood transfusion going on in a certain hospital setting. So they came up with a certain set pro forma for documenting the justification for blood transfusion. After implementing that pro forma and making everyone utilize that pro forma for documenting the justification for blood transfusion, the unnecessary use of blood transfusion reduced dramatically. So obviously it's going to have better impact, because it reduces the transfusion-related infections and the reactions that patients can get from transfusions. So these are the different types of audits that are going to find themselves into publication. Next, please. So these are the characteristics of a publishable audit. that the outcomes should be very important. You should audit the right topic. The sample should be large, because if the sample is large, it means that the audit that you are conducting is going to have a huge impact on a larger population of people. And if it has something to do with research or innovations, obviously that's going to find its way into publication. It should not only be generalizable, but the results of the audit should also be statistically significant. Only then it is going to find itself into a publishable audit. And as someone had asked previously, it should have a completed audit cycle. So a completed audit cycle means that there definitely should have been a second round done. Because if you conduct a clinical audit, you come up with recommendations, and that's the end of it, then obviously the readers would be more interested in what happened afterwards. When you came up with the recommendations, whether they were implemented or not, how much was the implementation, and what were the results after the implementation. So these all queries will be answered in the second round of the audit. So for publication, you should have at least 2 rounds of an audit. Next, please. I will now come to the summary of the presentation. Whenever you want to conduct a clinical audit, please select the right topic for your clinical audit. As learners, as naive students, it's better that you come up with simple topics to start off with, and later on you can come up with more practical and obviously vaster topics. You should follow the protocol of conducting the audit. Get a good team, get a supervisor or a good lead. If you are still not sure whether you can lead it or not, follow the template of getting the proposal accepted from the audit committee, and then conduct the audit and focus on publishable audit topics. Since it's the era of publication, everyone is interested in getting their data published. So focus on topics that will help you in publishing your audit. So that's it from my end, Umar. I'm very thankful to you all for your active listening, and I hope you would have gained some information and some knowledge from this presentation. If you have any questions, you all are more than welcome.
Thank you, Dr. Aliena, for the insightful presentation. That was indeed a very quite enlightening and educational one. I'm sure everyone had a lot to learn. You addressed the importance of clinical audits in healthcare and guided us through the steps where we can conduct an impactful audit, and taught us how to identify amicable topics. We will now open the floor for questions. Please use the raise hand function if you want to speak, or type your question in the chat box. We will address them one by one. Ma'am, let's start with a question by Fiza Safir. She's asking, if we conduct a quality improvement program for paramedical staff instead of patients, is that included in a clinical audit?
Thank you very much. Any audit that you conduct in a clinical setting is included in a clinical audit. So if you are, because obviously, if you are even conducting an audit on the paramedical staff, that also comes under the domain of a clinical setting. The paramedical staff also works in a clinical setting, actually. So whatever comes in their domain would be a clinical audit.
Another question from Ishtiaq. What will be the wording of complete audit of a topic for publication?
Well, you can come, if you please show the slide of my audit that I conducted.
Yes.
The purpose of showing that audit was that you can actually get to know what are the different wordings and the different sentences that we use.
Is it this one?
So, yes, thank you. The exact wording depends on the topic that you choose and the parameter that you want to actually conduct a clinical audit on. So there's not a single wording that you can get for all the clinical audits. The wording depends upon your topic and the parameter that you are conducting the clinical audit on. But please make sure that whatever wordings you decide or you select, there's no hard and fast rule for it. But whatever topic you select and you decide should actually communicate the whole message of your clinical audit. That should be very clear.
Another question from Naeem Afzal. Please throw some light on PDSA cycle. Could it take a course of an audit cycle?
Okay, thank you. The PDSA cycle, as I mentioned earlier on, has more to do with the quality improvement. And although it is somewhat similar to the audit cycle, but since it's not as, if we take into consideration the time duration, it's not as lengthy as a clinical audit, and we do not compare it with any standards. So you cannot call it a clinical audit cycle, but it should be called a PDSA cycle rather than a clinical audit cycle, because you do not have any standard against which you are measuring it. It gives you a more holistic approach. It has more to do with the quality improvement. Suppose if you in surgical ward, you think that the aeration of your surgical ward is not good enough. And for that matter, you do something that creates better air entry and better circulation of air. So it doesn't have anything to do with the comparison with the standard. You have just brought about a change in the atmospheric quality of your ward. So that is how you can run a PDSA cycle. Or suppose if you want to check the lighting in your operation theater, in your OT. So that is going to improve upon the visibility for the OT technicians and the OT staff and the surgeon. So these are short-term cycles that can be run in a couple of days' time. You identify a problem, you come up with a solution, you bring about the change, and then you see what is the impact of that change. So that is what a PDSA cycle is about. When it's about a clinical audit, you always have to have a standard against which you compare it. And in order to meet those standards, you bring about different ways and means to comply with that standard.
Thank you, ma'am. Another question from Dr. Amina Gul. With regards to publication, does a clinical audit fulfill the criteria of an original article?
No, a clinical audit is not going to fulfill the criteria of an original article. It's very good that you asked this question, because it's an excellent question. When I started conducting clinical audits and taking interest in clinical audits, I would also have the same query in my mind, whether it's going to give me the same benefit in terms of the promotions and the CVs and all those things, which an original manuscript is going to give. So unfortunately, the answer is no, because even there are certain journals that are not even accepting clinical audits for publication. So you should have that in mind. Not all journals are accepting clinical audits for publication, just as not all journals are accepting medical education related topics for their publication. So different journals have their own criteria, but I do believe that a time will come when certain institutes might privilege or benefit those who are conducting clinical audits.
Right, ma'am. Dr. Fazilat Bibi is asking, ma'am, can you please repeat the difference between audit and quality improvement? Does an audit on quality of discharge slips in KTH come as under the category of quality improvement project?
Okay, thank you for asking the question. I just explained the difference, so I think the question might have come a little earlier than my explanation of the difference between the PDSA cycle and the clinical audit cycle. But as far as the discharge slips are concerned, each hospital has a discharge policy. That's a standard. In UK, since there's not a hospital term that they use the word of a trust. So they have trust policies and trust guidelines, and they have guidelines for everything. Just as they have guidelines for admissions of patients, you cannot just admit any patient. You have to admit the patient who qualifies for admission. So same is the case that not every patient can be discharged. A patient can be discharged only if he or she qualifies for those criteria. And a patient cannot be discharged by anyone. Just as in our hospital settings, if suppose a patient requests the junior most doctor on the ward at 8 p.m. or 10 p.m., that there's an emergency in my home and I need to go, can you please discharge me? The junior doctor might discharge him or her. So that's not the case, because these are the patients who in the coming few days will represent to the hospital for admission because their initial problem had not been solved. So this is not quality improvement. When you have a guideline, when you have a standardized document or a protocol to follow against which you compare your own services and your own practices, that is clinical audit. That is not quality improvement.
Thank you, ma'am. Ma'am, a question from Fiza Safir. Ma'am, can we only include published clinical audits? in our IMT application?
Thank you. No, you cannot only include published clinical audits in your different applications or in your CVs or in your job applications. You can also include those clinical audits that you have conducted. But when in the summary, if you were there, this is what I mentioned too, that you should follow the protocol of conducting a clinical audit, that you should have a certain document in your hand once you have conducted a clinical audit. If it's from the Clinical Audit Committee, on which the chairperson of the Clinical Audit Committee and the Clinical Audit Committee members have signed and stamped that yes, you have conducted this clinical audit, we have come up with this recommendation, and now we are going to implement them. So you have proof that the audit has been conducted. Your job and your responsibility ends there. Whether your audit finds its way to publication or not, that does not matter. That is going to just benefit you for the publication matter. But even if you have a documented evidence from the Clinical Audit Committee or from your hospital that you have conducted this audit, you can show it as a proof that you have conducted it.
Thank you, ma'am. A question from Laibagul. How would we know that a topic we choose has already been addressed in a previous audit? Dr. Rahatullah is asking the same question.
Yes, thank you very much. Again, when you write a proposal to the Clinical Audit Committee, they are going to tell you whether it has been conducted previously or not. The same happened in my ward when one of my junior TMOs told me that he wanted to conduct an audit on the blood culture taking techniques, whether the correct method for blood culture taking is being practiced on the medical wards or not for patients presenting with fevers. And when he met the clinical audit personnel, he was told that another junior doctor is already conducting an audit on it. So that's why he then stepped back and started searching for other topics. So I don't think that's a very difficult area. Having a clinical audit committee helps you to solve these nitty-gritty matters. And obviously, there are so many other issues on which you can run clinical audits that even if you lose track of a single topic, you can get many other topics.
Thank you, ma'am. If anyone else has questions, kindly leave them in the chat box, or you could raise your hand and speak up. Kindly refrain from drawing on the presentation.
I'm not drawing on my presentation.
Not you, ma'am, the participants.
Okay, okay. Umar, I think we have got a few questions.
Yes, ma'am. The question. I have a slight technical issue at my end. The question is, is the hospital administration comfortable with addressing such issues of clinical audit?
Very good question. Yes, whenever we sit in the clinical audit committee and different presenters come and they present their audits, or by the end of the meeting, what happens is that the whole blame is put on the hospital administration, that we are having so many good points in our minds and we are having so many good recommendations, and the problem is with the implementation. But you see, when you are a third person looking at it from a distance, you can find problems in the administration, and you think that you have all the good points and all the recommendations at your end. But when it comes to the administration, they have their own limitations, as we all must be agreeing. They might be having other higher ups from whom they have to take approvals. They might be having financial issues. They might need extra staffing or extra material. But what we can do is to keep on reminding them of the recommendations and to keep on reminding them of the change, the better change that these recommendations will bring. If the hospital administration is friendly enough and if you are having a good rapport with them, I think they will not consider it negatively. Obviously, the aim of conducting a clinical audit is not to put the blame on the administration. The aim is to bring about a positive change in the overall environment and the atmosphere and the impression of your hospital. And I think it's an equal responsibility on the hospital administration as well as the healthcare professionals. So if they take it positively, they are not going to take it as a blame on them. And so far, I have not seen any member of the hospital administration taking it negatively. They are always trying to come up with support for us. I do know there are many loopholes. They do lag behind. I do agree to that. But I think our responsibility is to identify the problem and to give suggestions. And the hospital administration has so far not shown any remorse or any grief or any offense on these recommendations.
Thank you, ma'am. Ma'am, Qazi Adam Asfandiar would like to ask the question verbally, so I'm unmuting him.
Gigi.
Yes, sir, you can speak now. There seems to be some technical issues. He has also questioned in the chat box.
Okay.
He asks, for what period of time should we normally conduct a clinical audit?
Okay, thank you. A clinical audit usually should not take more than 2 or 3 months because once you have gotten the approval from the Clinical Audit Committee. So when you come up with a topic and you take an approval, the maximum it will take is a week. After that, you start your data collection. So that should be maximum for a month. And after that, you come up with your data analysis and then presentation. So I think that should take another 1 month. So not more than 2 or 3 months, the first round. And then the second round, again, the same 2 to 3 months. So you can get 2 rounds of a whole audit in at the maximum 6 months.
Right, ma'am. Ishtiaq is asking how to convert audit into original paper.
Okay, thank you. Now, the presentation that I shared with you of my own audit, that was a PowerPoint presentation, which I have shared with you over here. All journals, as I told you, not every journal is accepting clinical audits for publication. Journals that are accepting clinical audits for publication usually have their own guidelines and criteria for certain manuscripts. So they have their own templates, but usually they have a title and the background, the aims and objectives, the results, and then the discussions just as original articles. So the format of a clinical audit for publication purposes is not much different than an original manuscript, but I cannot give you a single format for that because it is the domain of the journal that is taking up the clinical audits for publication. They have their own format for publication of clinical audits.
Right. Mohammed Naeem Afzal is asking, does publishing an audit create a political impact on reputation of the institution?
Very good question. Thank you. Actually, whenever you are conducting an audit, you should not go into those aspects of the institute that, like what I mean to say is that you should not conduct an audit on debatable topics. Because at times we did come across a certain original manuscripts and certain audits and certain qualitative studies in which this was creating an issue. Because at times when you want to highlight the reality, it might create a little bit of a problem in the reputation of your institute. For that matter, it's better that either, if possible, you do not mention the name of your institute, or where possible, you should not go into debatable topics. Because the impact of the clinical audit should not be on the highlighting of the name of the institute, rather than whether the clinical audit is bringing an impact in the patient outcomes and the provision of services. So our aim is to actually disseminate that information rather than disseminate where this clinical audit was conducted. So if anonymity on the basis of the institution can be kept, then it's better to conduct it accordingly. But where you think that the anonymity will be a problem and you might not make the name of the institute anonymous, then it's better that we do not go into debatable topics. Otherwise, the question is very pertinent. It can create such problems.
Right, ma'am. Another question from Sirajuddin. Is audit report acceptable to the CPSP as alternative to articles or synopsis dissertation?
Thank you very much. Very good question again. No, these are not acceptable to CPSP as a replacement of your original manuscripts. No.
Ma'am, Dr. Amina Gul has raised her hand. Dr. Amina, you can now unmute yourself. Dr. Mohammed Saleh Faisal has asked a question. Can clinical or educational audits be done in other institutions from whom we need to take approval in such cases?
Okay, thank you. That's also a very good question. You can conduct a clinical audit in other institutes. Only there are two ways by which you can do that. If an MOU has been signed between your institute and that other institute, so yes, their researchers can come and conduct research in your institute, and you and other researchers can go and conduct research in their institutes. By research, I mean original research or clinical audits or whatever you want to conduct. If that is not possible or if that has not been done, then you make a team of certain doctors or certain healthcare professionals that is an amalgam of healthcare professionals from your institute and that institute. So you, representing your institute, take approval from your institute, and that other team member representing his or her institute takes approval from that institute. Since I'm also a member of our hospital research committee, we do at times have certain trainee medical officers that are conducting a multi-institutional or a multi-center research. So we give them approval from our hospital, and we tell them that you are this institute. This approval is for this institute. Take approvals from their own institute. So the same applies to an audit.
Thank you, Dr. Aliena Badshah, for such a nice presentation. Special thanks to Dr. Iqbal Haider for giving us opportunity to run on key aspects of research. I have a question, not a question, rather what I was looking at is this slide, which is just in front of us. And if we all look at it, it says that this proposal aims to conduct a clinical audit to evaluate the documentation of these NIHSS scale in the initial assessment of inpatient ischemic stroke patients. So Dr. Aliena, what I was thinking is in audit, we address a problem, and in original research, we also address a problem. If I simply remove this word of the proposal aims to evaluate the documentation of these scales rather than just putting like doing simply the clinical audit. So probably we can present this problem as original research as well. Need your suggestions on this.
Okay, thank you very much, Dr. Amina. Your question is very pertinent, and you are very right in saying that. But whenever we talk about research, we try to come up with issues that have not already been addressed or issues that are already not in practice, because research always looks at newer things. So the NIH stroke scale is already in action. It is being practiced throughout the world by stroke specialists. And so I don't think that conducting a research on that particular stroke scale would give us any benefit if it is not being practiced over here. Then there might be certain limitations or there might be certain other issues which need addressing. So that's the basic aim behind conducting this clinical audit. And that is the importance of this word of documentation over here, that this audit has nothing to do with the NIH stroke scale per se. It is basically interested in whether this stroke scale is being documented or not. So I hope you got my point. But yes, if there is another topic, like let's not just discuss the NIH, you can find some room for research, then yes, definitely you can conduct a research on it.
Thank you, ma'am. Another question from Ihab Iftikhar. What measures are in place to prevent data manipulation or selective reporting to present favorable results?
Okay. Well, yes, you are very right about that, actually. When a person is conducting research, he or she is admitting and is taking the responsibility that when he or she is conducting research, his or her aim is to bring about a positive change rather than to manipulate data. For this matter, there are certain softwares that can check whether this data has been manipulated, this research has been manipulated, just as we have different plagiarism checkers for those who are just copy pasting previously conducted research. Another important point over here would be the importance of the clinical audit proposal. Once you have come up with a topic and you are filling in the proposal form and you are submitting it to the Clinical Audit Committee, the responsibility lies on the Clinical Audit Committee to scrutinize it thoroughly and to make sure that there are no loopholes left for any manipulation of data. And then by signing the declaration at the end, you actually confirm that I am not going to manipulate the data and I'm not going to use it for any other matter. But obviously, I do understand that plus minuses still occur despite all these declarations and despite all these cases. But then I think it depends upon the person's own personality for which matter he or she wants to conduct the clinical audit.
Right, ma'am. If there are any other questions? Abu Bakr Siddiq has replied to Dr. Amna's question by answering, research is concerned with discovering the right thing to do. Audit is concerned with ensuring that it is done right.
Well said.
All right, everyone. Thank you for showing such an interest in today's session by participating in such large numbers and engaging in a very positive Q&A session. The topic was indeed interesting and also showed that Dr. Aliena Badshah addressed the topic in the best possible way. Now I would like to take this time to tell you about our next webinar, the webinar on editorial writing. The Our next speaker is Dr. Suleiman Elahi, and I highly recommend tuning in for that session for all those who want to learn the nitty-gritties of what editorial writing is and how it can be proficiently written. It is an important learning venture for pursuant medical researchers. I would also like to share that the International Research Conference, KMCIRC, has been scheduled for the 2nd and 3rd October 2024, and it is accepting abstracts. Kindly do so before the deadline. The theme for the upcoming research conference is Bridging the Gap Between Classroom and Clinical Avenues. The poster is being displayed. With that, today's session has come to a formal closing. Thank you all for tuning in. Thanks once again for our hardworking faculty for the smooth session, and a special thanks to the Director of Medical Education, PGMI, Dr. Aliena Hadi. We look forward to your participating in the upcoming sessions. Once again, thank you, Dr. Aliena Badshah, for your time
My
and
pleasure.
expertise. This is your moderator signing off. Thank you, everyone. Have a good day, and Allah Hafiz.